something more therapeutic in nature compared to mostly diagnostic applications of SPECT CT, and how we use it in our Tc99m microsphere therapy. Just to give a broad overview of what we're going to cover, I hope to cover in the next 30 minutes. There are at least 4 different things we could use SPECT CT in applying to microsphere therapy. The most obvious, of course, is improved diagnostic detection of extrahepatic localization of our surrogate, the Tc99m MAA. And I'm going to hope to show how we apply the SPECT data for quantitative dosimetric planning when combined with CT hepatic angiography. Then secondly, there is CT data, and there is opportunity to use the CT to estimate the lung mass, which we apply. We apply the lung mass into the dosimetric planning using the actual lung volumes rather than the MERD assumption of lung mass. And lastly, post-treatment SPECT CT can be used to look at the distribution of atrium. Although I have a little caveat, which is PET is probably superior, so we say put it there as if PET is not available. Oh yeah, we do have that big monster of a machine in SGH too. Okay, just to give you a broad an idea of our experience, on the left side is probably a more typical case mix or a referral pattern that you have in most centers where about 70% or 60% are metastatic cancers in the liver, whereas in stark contrast in Singapore General, liver cancer is more than 99% of our case referral, and even, well, actually half of that 175 patients are actually trial patients involved in a multi-center trial. But even if you take out half of that number, we still have a tremendous bias and skew towards liver cancer. And part of the reason is that liver cancer ranks number 4 in our male cancers in all of Singapore. And the worldwide distribution is also kind of skewed towards Asia and Africa. And just a little bit of general knowledge, HCC distribution matches the distribution of hepatitis B and hepatitis C. So I'm going to dive in straight into yttrium therapy. I think I'm not going to go into the details, but just to show you that that we fit into the bigger picture of some other treatments that are available for these patients. And basically only 15% of liver cancers are amenable to curative resection. Those with bad liver function may potentially may be referred for transplant. But I think I'm going to skip the details and to also say that besides SIRT Radioembolisation therapy, there's also transarterial chemoembolization, as well as a new drug, which is a tyrosine multi-kinase inhibitor, sorafenib being one of them. Okay, so I think, well, as far as yttrium microspheres are concerned, there are 2 products commercially available: high specific activity thyrospheres and slightly lower specific activity SIRT spheres, where more particles are needed to be administered per therapy. The particle size, 20 to 60 microns, is similar to Tc99m MAA, which is why we use MAA as our surrogate for treatment planning. So, but I do take issue with the term radioembolisation, as is normally referred to, and well, globally the accepted term is radioembolisation. That's because it has been driven a lot by interventional radiology. But in actual effect, yttrium microspheres are a lot smaller compared to the large particles used in arterial chemoembolization. And we know from our understanding of radiobiology that radio resistance is associated with tissue hypoxia. So in actual effect, yttrium microspheres produce little or no embolic effect, and we do actually want adequate tissue oxygenation in order to have the free radicals to produce the destructive effects of the radiation, in contrast to TACE, in which the ischemia drives the antitumor effect, as well as the drug delivery. So these are just what the microspheres look like in the tissues. Here's the microspheres, the little black beads in the liver with some surrounding reaction. And we know that we know where we don't want it to go. And here's a patient with the gastritis, post-yttrium therapy, showing the uterine microspheres in the gastric wall in the biopsy. You also know the other known hazard is radiation pneumonitis, and here we see a particle, a microsphere particle in the alveolar wall. So I think we all know these are the side effects we want to avoid: radiation damage to the liver, to the lung, as well as to other organs that may inadvertently accumulate the atrium. So accurate treatment planning or pre-treatment planning is essential to minimize these side effects, at the same time delivering tumoricidal yttrium-90 activity. And this is one of the vendors that actually has supplied us, that generally gives most treatment centers the instruction manual, the training manual that guides therapy in most sites. And the training manual suggests three methods for pre-treatment planning. The first is the least scientific and most and seldom used. The body surface area or BSA method is the most popular method because it is following the recipe book without really having to understand how it works. And actually, we don't really know actually how it was arrived at. But some people believe it is the vendor has used has a consult an expert group of people, and the BSA protocol is based on possibly based on median response rates. The partition model is the most scientific method. It's validated based upon MERT principles of radionuclide internal dosimetry, and it's called a partition model because there are three compartments: the tumor, the non-tumorous liver, and the lung. But the main limitation of the partition model is that it is thought to be only applicable when tumors are more discrete and focal, and vascular access to those lesions permits selective infusion. And in a large number of patients who have multifocal tumors, it may be difficult to draw regions of interest, defining the tumor versus the normal liver parenchyma. And here's an example of what a typical candidate that would be suitable for partition modeling. And the three partitions or three compartments are the tumor here, the non-tumorous liver, and the lung. So this is the MAA scan. If you look at the scan, it's 2008. We have abandoned this methodology in SGH. Actually, we moved on to SPECT-CT, which is the purpose of my talk here. Now, this is when a typical situation when partition modeling has its limitations, and when you have multifocal disease, it is very difficult to be certain whether this is tumor or normal liver. So overlapping activity in multifocal HTC makes ROI placement difficult and unreliable for accurate partition model dosimetry. So in one of these schemes of treatment planning schemes, if the lesions, it has been thought that if the lesions are discrete and clearly definable, then we go on to partition modeling. Otherwise, the BSA method is recommended. But within SPECT-CT, we believe that we can apply a more scientific partition model dosimetry to a greater than 80% of patients in our practice. So the most obvious benefit of SPECT-CT obviously is the improved detection of extrahepatic localization of technetium MAA. And so here's an example. The smaller image is a planar image. You see tumor, you see what looks like a stomach. And what about this? So on the SPECT-CT, there's gastric wall activity, and we know based on the angiography that the culprit is the gastroduodenal artery or GDA. It's in fact the most common vessel that we want to avoid. But that other block lower down on the SPECT-CT is in fact pancreatic head activity that is supplied by the same GDA artery. So this is just one example, and we know that SPECT-CT allows us to see other potential problems such as yttrium or MAA potentially going to the stomach, to the gallbladder. We've seen diaphragm, we've seen adrenal glands. And what about this one? What do you think? This is SPECT-CT, MAA SPECT-CT. Anyone has a guess what this might be? Coming down is in fact the falciform ligament. And so that's the falciform artery, and there have been a few case reports, and we have actually reported 3 actually of these patients, and one of them actually developed radial microsphere dermatitis as a result of the yttrium-90 going to the skin. So just an example. Okay, so the first obvious benefit is the identification of extrahepatic localization of MAA, which is much better than the SPECT-CT. And this scheme, I'm not going to go into great depth except to say that SPECT-CT allows us to make those plumbing decisions. I don't mean to belittle the skills of our interventionists, but these are in fact plumbing decisions as to whether it's okay to proceed based on the vascular anatomy, whether a repeat angiogram might be necessary, whether any particular vessels need protective vascular coiling, and most common being the GDA, to avoid the yttrium going to stomach or to other organs that might be problematic. Of course, this will also guide the interventional radiologist in placement of the catheter, whether a superselective or a different vascular approach is needed. Or outright, we occasionally do encounter difficult vascular anatomy with outright rejection from SIRT based on complex anatomy. And lastly, of course, guide catheter placement. And I think most studies show that about 20% of patients will fail the MAA study prior to yttrium therapy on account of lung shunting or difficult territories or difficult vascular access. So now the next section of my talk is on precise dosimetry planning. Now SPECT inherently has quantitative data, and actually we can potentially extract more useful information than just qualitative information of extrahepatic localization. And to do this, in the interest of time, we have actually published our results, but to do this, we combine additional information provided by catheter-directed intra-arterial CT hepatic angiography. This is the CT scan done in the angiography suite for each vessel that is selectively injected with contrast. And we use that data, combine that information with our MAA study to identify each of the vascular territories, which we hope to divide our yttrium dose into, and to calculate the dosimetry for each vascular territory. So that is what we call the artery-specific SPECT partition modeling, which is based on this MERD approach. Now, first to get some things, some benchmarks. It has been generally felt that the tumoricidal dose is at least greater than or equal to 120 Grays to the tumor, provided the liver parenchymal limit is not exceeded. Although in a very recent paper by a French group, they've advocated a much larger tumoricidal dose, which I think I see some eyes widening, and I don't think that is shared by most practitioners. Similarly, what about the safety thresholds? Most experts would set these thresholds as upper limits of in gray dose for healthy liver, for cirrhotic livers, or in livers who have been assaulted with chemo. And this would be what in our current practice, the dose limit for the lungs. Again, that paper, the French paper, has cited rather frightening dose limits, which are not generally applied in most other places. But interestingly, this paper actually also applies SPECT-CT dosimetry in the calculation, although the details I don't have time to go into. So now to give you some examples, I'm going to take you through some examples of how we do the SPECT-CT artery-specific or region-specific, vascular-specific dosimetric calculations. So here's an example of a very large tumor. In this case, the tumor has got two vascular supplies. This is the DSA of the right hepatic artery injection. And also this same tumor has a portion which is supplied by the left hepatic artery. So on the intra-arterial CT, which is injected through the right hepatic artery, you see that portion of the tumor that is supplied by the right, and this portion supplied by the left hepatic artery. And this information is applied by eyeballing, in our case, to the SPECT-CT data to delineate the vascular territories on our MAA study. So I'll just take you through, in fact, that case maybe while it's fresh on your mind, I'll go straight to that particular case while it's fresh on our minds to show you in schematic or an example of the worksheet that we use. So that's the same case example. This is a patient with a large tumor and the left and right hepatic arteries, each supplying different portions of the tumor. And we draw, okay, let me show you. The region of interest guided by the CTHA for each lobe of the liver. We have identified the tumor. In this case, this is the territory. The blue outline represents the territory of the right hepatic artery, and the yellow, the outline, the vascular territory of the left, and then the tumor portion, the sub-portion supplied by each of the vessels. And this delineation between the vascular territories of the two vessels cannot be determined on MAA study. That comes from the CTHA study. And so these numbers, the counts, the mass of each tumor of healthy liver is plugged into the dosimetry worksheet. And it's a very long worksheet, and actually you can find this on our departmental website. And if you downloadable, you can use the data to apply the same methodology in your practice. Now, the other thing I wanted to draw your attention to was that based on the SPECT-CT, the standard partition model for this kind of dose calculations, they presumed standard man in MERT dosimetry has a lung mass, or total lung mass of 100 grams. And this is a correct across the board for all patients. And I want to show you why we want to do individualized lung mass, because our average Asian man referred to us for SPECT-CT, for Y-90 is actually smaller, and lung volumes are smaller. I'll come to that in a moment, but just to take you through some other typical examples of the dose calculation. So here is one example of the easy one, a single vascular territory. Okay. So here, again, the point I want to highlight is that we are in this kind of analysis, it gives us the opportunity also to exclude what is deemed to be necrotic tumor. So the necrotic portion of this tumor is excluded from our tumor mass calculation. So this was meant to be a single arterial injection into the common hepatic artery. So there's only one vascular territory, yellow, and the tumor, as well as the necrotic portion of the tumor, which we have, excluded from the dosimetry calculation. So the counts, the tumor masses, the normal liver is plugged into that same worksheet, and in this case, it's a single vascular territory, which we plug into the partition model dose calculation, and we arrive at, in this particular case, a recommended dose of 4.64 gigabecquerels, which would deliver, 11.8 grays to the lungs. Where is it now? Those to non-tumorous liver, 15 grays. Those to the implanted tumor, 90 grays. Okay. And again, in this earlier dosimetric worksheet, we made use of the fixed lung mass of 1,000 grams. Okay, so now this slide is part of a very large schematic of the treatment planning approach, which I'm not going into, but I just wanted to highlight that applying the methodology that I just described allows you to predict accurately if your Y-90 therapy intention was for a radiation cementectomy or lobectomy. At the same time, because we are able to predict in advance where our dose is going to be deposited, we also can predict in advance which areas of the tumor or which tumors would be undertreated or non-treated, and in which case these areas we may need to address them separately, such as with radiofrequency ablation or very careful surveillance. So being able to predict in advance which areas that we need to be on the lookout for is an advantage to using this methodology. Okay, so the details of the, we have actually to date treated about 80 patients using the methodology I described. But the publication has just come out in JNM electronic edition last month, in which we reported just 10 cases, 20 vascular territories. The reason being we have wanted to look at longitudinal data. So these studies were analyzed in detail, and 20 arterial territories in 10 patients with a median follow-up interval of 21 weeks. And amongst many other findings in the analysis, what we found that if we analyze the results strictly as brachytherapy, U-90 therapy planned according to this methodology achieved a 100% tumor regression. So there's high index of prediction of the outcome using the dose calculation beforehand. And these were some of the summary of the findings, but what is significant is the mean tumor absorbed radiation dose of greater than or equal to 91 grays was found to achieve a 100% tumor response rate in this limited study. So that publication, basically the conclusion was that accurate dose estimates are possible with SPECT-CT for tumor, lung, and liver. We have greater precision control beforehand over the dose targets, and if the treatment intention is partial segmentectomy or lobectomy, we can plan and accurately deliver the dose we want to give. We can deliver lesion-specific or sub-lesion-specific, we can determine lesion-specific or sub-lesional dosimetry to identify problem areas that we might not be targeting effectively. And potentially, you can apply this methodology to use the yttrium for other tumors in other organs, such as in the adrenals and kidneys. And in fact, I'm just going to show you an example of a patient with a very large adrenal GIST tumor sitting on top of the right kidney. And this is the inferior adrenal artery. And here's a selective injection into the inferior adrenal artery, showing the large adrenal GIST tumor that was not responding to Gleevec. And the patient also had a solitary liver metastasis. So in fact, this patient was referred to us to address the liver metastasis, but we thought we could attempt a U-90 therapy for the adrenal tumor as well. And we did indeed. And here's the intra-arterial CT of an injection into the right inferior adrenal artery, showing good localization of the contrast. And this should have been the MAA, but I didn't have a good example picture. But this is the post-therapy Bransonang PET showing U-90 or SPECT CT showing U-90 in the tumor after treatment. And here is the tumor. And this was the other tumor metastasis in the liver, very small solitary liver metastasis. This was the intra-arterial CT, and again the same method of analysis was applied. And just to show you the dosimetry worksheet now, in the case of the adrenal tumor, that injection into the right inferior adrenal artery exclusively supplied the tumor. So we applied only a two-compartment model in this case, because there was no healthy adrenal to talk about. So the same mathematics, except that there's no healthy adrenal gland, and these were the dose estimates, dose planning calculations. And just to show you that partial response in that adrenal tumor was reported at 16 weeks. This was the post-therapy Bransonang scan, and 16 weeks later there was some tumor regression in that adrenal tumor. Okay, so now about lung mass. Again, CT already has that information, and just simply applying the isodense contour to the outline of the lung, with a little bit of help of a manually override sometimes in the mediastinal margins, we are able to determine the lung volumes and lung mass for these patients. And anecdotally, I just wanted to tell you that that generally our patients have much less smaller lung volumes than 1,000 grams, and well, this work calculation goes down into the tumor masses and the lobes as well. But as a proof of this concept, what caused us to do this was that we had a patient who developed radiation pneumonitis, even though our dose calculations seemed all right. And when we went back retrospectively to analyze the lung volumes, this patient was a very small patient, and the lung volume turned out to be less than 800 grams. So we believe that this will give us much, when we plug this lung volume or lung mass into our dosimetry calculation, we believe that we can customize the dose better than using a fixed assumption for the lung mass. So that example, in this case, other example, the lung mass is determined by CT was only 618 grams. Okay, so last bit now, coming to lunchtime. Post-therapy Ramsar lung SPECT CT. I think most of us, as soon as you've got your SPECT CT, would put your patient under the scanner and do a SPECT CT after the uterine treatment. And this is exactly what we did. And the advantage of doing this imaging, first it confirms whether your MAA predictions were true and correct. It also helps you identify areas that were undertreated or inadequately treated. But I think we all now know that uterine PET is possible as well, and that is because although we always thought it was pure beta emitter, there are actually 32 pairs per million disintegrations, and capturing the photon pairs using a PET scanner, we can get much better quality uterine 90 PET. So here's the SPECT CT, and this is the same patient after uterine treatment put under a PET scanner. And in fact, we believe that the PET gives us a much more confident answer as to if any areas within the liver or tumors are inadequately treated compared to the blurry Ramsar lung, which we know of course, the limitations. Okay, so I'm going to just sum up now that SPECT CT enables personalized uterine 90 therapy, improves safety and efficacy. It allows precise dosimetric planning when used in conjunction with CT hepatic angiography. The CT allows you to measure the lung mass, which you can plug into the dosimetric calculation. It provides better detection for extrahepatic MAA activity, and potentially we can apply this methodology to other tumors as well. Thank you very much.